little bit late. My name's Anna Hanlon-Dearman. I'm here on... Oh dear, I'm getting feedback, so I'm just going to hang up there. Okay, Sydney? Sure, okay. Sorry about that. So I'm here on behalf of Better Nights, Better Days for children with neurodevelopmental disorders, which is a program that is an online program designed to support kids and their families who have neurodevelopmental disorders and who may be struggling a bit with their sleep. This is a program that is funded by Kids Brain Health Network. My name's Anna Hanlon-Dearman, and I put a little picture of myself because it's sometimes funny to just see slides without seeing a face, so I'm hoping you can at least see my face there once. I'm the medical director of the Manitoba FASD Centre, and I'm going to talk to you a little bit about sleep and FASD. So there are a number of risk factors for sleeplessness in FASD, starting with, of course, the impact of prenatal alcohol on different neurological neurotransmitter systems that have a direct impact on self-regulation and sleep. But in combination with that are a whole bunch of other factors, some which are directly related to FASD, and some which are really the family and caregiver context that any child or family lives in. Children with FASD can experience some learning or behavioral challenges that can really have an impact when we're trying to help them learn about their sleep and manage some of their behavior. They can have a number of sensory processing deficits, which we definitely see both as a direct impact on sleep and as a result of sleep difficulties. They may have impaired communication, which means that it can be difficult for them sometimes to understand some of the sleep hygiene practices that we really want to encourage in them. And it can also be difficult for them to tell us about their sleep or express that in a way that helps us all understand what may be needed in a particular situation. So really the point of this picture is to help all of us as families, as caregivers, and as care providers think about sleep in a really holistic way for kids. Alcohol is what we call a neurobehavioral teratogen, and what we mean by that is that alcohol, when taken prenatally, can affect the developing baby. And it can affect children in various different ways, but often one of those things is that the adaptive difficulties in day-to-day functioning can really often be out of keeping with intellectual functioning. And part of this is because of the damage that alcohol can cause to some of those integrative processes. And the really nice thing that we know is that while that may occur, that sleep can be really one of those restorative processes that can help mitigate some of that. So while we may see children who have impulsive behaviors of difficulties with self-regulation and sensory integration, sleep can help that. And sleep can really, having a good night's sleep can really make a big difference for everybody. So as I said, sleep is self-regulatory. It can help us stabilize our mood. It can help us be less reactive or be more appropriately reactive. It can help us think a little bit better. And it can also help us with our stress reactivity and our behavior. So there's lots of really good reasons to help kids, especially kids who may be a bit predisposed to having some of those difficulties. As parents and as caregivers, we can really have a positive effect on making days better for kids. I like to think of children who have difficulty with sleep as either being overtired or overwired. The overtired, I think we're all familiar with, looking tired, feeling tired, being grouchy or crabby because of that. But kids with FASD can also be a little overwired when they're tired. They may become more hyperactive or disorganized or more challenging, or learning may be more difficult. And things that we've typically done in the past to help them may simply not be working as well when they're overtired. Some of the recent research that we've seen has really shown us that sleep disorders are really prevalent in kids with FASD. In this particular study, almost 60% of kids had some type of sleep disorder. A third had what we call parasomnias, or problems like talking in your sleep or walking in your sleep, and certainly insomnia is very common as well. Sleep apnea, I'm not going to talk as much about, but can certainly address any questions on. Polysomnograms, the PSG that you see up on your slide there, is our overnight sleep study that we sometimes do. We don't have to do it in all kids, but when we do it, we see that sleep is really fragmented in kids with FASD. They're not as efficient sleepers. They're more wakeful, and they're more wakeful more often. And most kids with FASD have shown an abnormal melatonin profile. So melatonin is that hormone that we all have, that we secrete from our pineal gland in our brain when it's dark, that helps cue us to sleep. It helps us feel sleepy, and it helps us sustain our circadian rhythm. So when that secretion is untypical, we may have more difficulty sleeping. The model I'd like everybody to think about, and maybe this is a model that's a little bit more care provider oriented, but I'd like everybody to think about, is that while we may have something initially that's disrupting our predisposition to sleep well, in fact, there's a whole bunch of other factors that we need to consider. We have to consider the sensory reactivity of a child and what their sensory processing patterns may be. We have to consider what the impact of their day-to-day activity is on sleep, and what the impact of sleep is on our day-to-day activity, and how can we support that? Because while some of those factors at the beginning of this slide are simply things that are what they are, in day-to-day life, we can really help support kids and families and make life a bit better. This slide is here to help us recognize that when we help kids sleep better, or when we get kids who are so-called difficult sleepers, when we can help them, we can also help the functioning of the family unit, their siblings. It has broader effects on daytime functioning. The goal here for us as we work with families and individuals with FASD is really to make life better, to reduce that burden of care related to sleep. And we may have to do more than one thing at a time. But I do want to caution people that kids who are have a few extra things to deal with, kids who have had histories of trauma, especially recent histories of trauma, kids who may be in and out of hospital on a chronic basis, or kids who are newly adopted, we may have to do things a little bit differently and be a little bit more patient, because they have a few other things that we really need to be cognizant of. But we can still get there. It's really important to have a team approach and work with whoever the members of that particular child's team are. Their therapists, their family, their other primary care workers, community-based workers. Everybody can have a role to help support day-to-day functioning and sleep, because I include sleep in day-to-day functioning. We really need to get at this early, because the secondary consequences of being chronically sleep deprived really impact everybody. And we really have to look at what the profile of strengths and weaknesses are in an individual child, and work with the strengths, support the weaknesses and the challenges. And as I said, things are often a bit complex. So the general principles that I want to leave everybody with are, number one, always thinking about sleep hygiene, but let's think about it a little bit differently. Let's start with where the family is at, where the child is at, and how we can enhance what's already working, and then think about what the priorities are for developing strategies that work in other areas of sleep hygiene. And this is really a back and forth conversation that we have all the time with families. We need to think about the day-to-day rhythm of a family's life and see what we can enhance again from a sleep hygiene point of view. We want to work with stabilizing behavior and supporting family, supporting sensory considerations. And finally and intentionally, I want to talk about medication last. I want everybody to think about medication from more than one point of view. Number one, think about what medications that child may already be on that may impact sleep. stimulants, for example, can have an effect on a child's sleep. Secondarily, I really want people to think about how we can use medication if we need to enhance sleep. So this is the Better Days, Better Nights website. I would encourage everybody to go onto the website and explore if this is a good option for you, but I'd really encourage, because the information on this website is really, really helpful for families. And you can contact the coordinator of the study if you wish to participate. And here's our social media sites. So with that, I think I'm going to open the site for questions, and I'm happy to address any questions. Thanks very much for your attention. Are there any questions I can take? I see a question here about melatonin. And the comment is that this particular family's daughter has been using 3 milligrams of melatonin and it seems to help. It's a great question. So melatonin, as I mentioned, is a hormone that we all secrete from our pineal gland, and it does help with circadian rhythm regulation, so setting our clock day to day, so to speak, and it has some sedative properties, so it can help kids fall asleep. I do use melatonin, and it can be very effective in kids with sleep hygiene, with FASD, but it has to be used with really great sleep hygiene. It makes sense to give melatonin in association with dimming the lights and having a really good, regular, predictable nighttime routine. It isn't a panacea all the time, but as I mentioned, the study that showed that kids have trouble with melatonin secretion may benefit from melatonin. So I can support the use of melatonin in many kids. Not all kids react to melatonin the way we would like them to. So I think you have to do that with your primary care provider. I see another related question about, is it good practice to continue using melatonin on an ongoing basis? And I think that's really a question you need to address with your care provider. Melatonin is relatively safe, and so it can be used for longer periods of time, but some kids do seem to become a bit used to the effects of melatonin, and so families would find that the melatonin no longer works as well. And I think melatonin also shouldn't be seen as a substitute for good sleep hygiene practices. So I think there isn't an exact answer as to how long you should use it for. I think that's a discussion you have with your primary care provider. Are there any other questions? maybe I'll just also mention about melatonin. Melatonin is secreted when the lights go off. It's suppressed when the lights go on. So one of the practicalities of using it with good sleep hygiene is if your child is wakeful during the night, and if they're on melatonin, you really should do what you need to do to help them get back to sleep with the lights off, if at all possible. So keep the lights off, be brief and boring. Don't turn on screens to help them sleep. Really help encourage self-soothing in kids, and really give them those environmental messages and cues that nighttime is for sleeping and they need to go back to bed. Are there any other questions or comments? Oh, here, I have a comment here. The comment is about restlessness and taking melatonin. He's a pretty short sleeper, 3 to 5 hours, and they're hoping to get a sleep study done. So that's a great question. 3 to 5 hours is clearly a short amount of sleep for a 9-year-old boy. And what a child would need would be a really comprehensive assessment with their primary care doc, because I think one has to ask questions about what's going on during the sleep. Are they snoring? Do they need that overnight sleep study that would be helpful in looking at things like obstructive sleep apnea or restless legs? What else can we do in the meantime? So really, really important to look at that from a comprehensive point of view. I hate to say, but I know that in many areas, the wait lists for sleep studies are actually quite long. So you would have to address that in your area. I see another comment here about activities until, in this case, 8:15 at night, and then getting home till about 9. So that's always a little bit of a challenge, because one would really like to support regular physical activities in kids. Usually the rule is trying to not have vigorous physical activities within 2 hours of wanting to get to sleep. So I don't see how old this particular child is, and that might be an issue if she's sort of a younger or mid-school age kid, where you're hoping to get them to sleep probably not too much after 9. To think about, I think you really have to think about how your day-to-day routine, what it looks like, and how you can incorporate calming activities when that may even start when they're finishing their swim lessons. Oh, there we are. She's 11. Yeah. So for sure, when she's finishing her swim lessons, what can we start even at that time to help her relax? Can we start messaging her? Maybe she wears her pajama bottoms. Lots of kids do that nowadays. Maybe she has, a glass of warm milk to help encourage our calcium and magnesium. Maybe she doesn't have screen time after that. Maybe there's something relaxing she can do when she gets home to help her transition from being out and having her swim classes. And maybe there's another time she can have swimming, although I certainly recognize that sometimes that's easier said than done. I think that, again, is a conversation that you have, and really think about the day-to-day patterns. There's a very wise person who said a good night's sleep begins first thing in the morning. So let's think about our light sources first thing in the morning, our activity levels, keeping them higher earlier in the days, relaxing them as the day goes on. What would help her from a sensory point of view to relax? A whole bunch of different factors that might be helpful. Oh, and she's homeschooled. Yeah, great. So maybe there's some ways of thinking about what the day-to-day activities look like, and when her what's arousing for her. One of the things that's interesting, what's relaxing and what's arousing for different people varies. Just as a simple example, for some people, having a nice warm bath before bed can be very relaxing. But for other people, having a warm bath before bed is actually alerting for them. It wakes them up a little bit. So I think it's really important to think specifically, where can we enhance relaxing activities and where can we readjust other activities. I have another comment about another one who has struggled for a long time with sleep, which is very typical of the kids that I see, falling asleep and awakening at night. They're doing lots of good things, predictable sleep routines, dim lights, sensory integration. I just have to keep reading this. Yeah, they struggle with self-regulation, right, and recognizing fatigue. So the question is, does she maybe need to stay up later? It's a great question, and I don't know the answer to it, but here's what I'd suggest that you look at. There is kind of a math of sleep for everybody, and what I mean by that is I often ask families to do a sleep log, and it's a pretty specific sleep log. It's not a narrative handwritten one, but it's actually kind of a graph sleep log where I can really get a sense of how many hours sleep does that child get per night? When are they in bed? When are they awake? It looks at patterns. But by knowing how many hours of sleep as a starting point that they're actually getting, I can also do some work in terms of thinking about what's an ideal amount for that child. And the range of sleep needs is actually quite big. So for the same age, one child might need 6 or 8 hours of sleep and another child might need 12 hours of sleep. The ranges can be quite large. It's important to determine what your particular child needs, what they're actually getting, and how we adjust bedtime. And I always start in the morning with that. So for example, if you're a 10-hour sleeper, which probably this child isn't, but if you're a 10-hour sleeper and you wake up at 7, that means if you slept through the night, falling asleep at 9 the night before would give you the 7 hours, 3 hours till midnight and 7 hours after that. But if your child is a 7-hour sleeper, in theory at least, if you want them up at 7, they're not going to feel sleepy until midnight. Midnight is probably not a realistic time for most families and most younger kids. So I work with families to say what is realistic in terms of expectations for getting in bed, falling asleep, and waking up in the morning. And that's very individual for every family. So maybe as a starting point, I'd really encourage you to log that. Think about her sleep need, her sleep, what she's actually getting, and play around with the math of it. Yeah. So unfortunately, I have to go. So I think I need to close. But what I'd like to do is thank everybody very much for their attention, for their awesome questions. They're really common questions that I get asked all the time. I'd really encourage you to talk with people who help provide support to you and your children. And go on to the Better Days, Better Nights website for more information about the program. Thanks very much, everybody.